No.
We're on. Oh, we're live, and this is Senate Health and Welfare. Yeah, continuing our meeting on April 23rd. Well, thank you all. That was a really terrific meeting we had this morning on some of the issues related to transformation, hospital transformation, but really healthcare system improvement overall. It's good. So, Martine, you take over, and Jen, why don't you come up and we'll look at the H13 proposal. Okay.
Good morning, Jen Carty from the Office of Legislative Counsel. To join the student meeting, and I will put up, this is, we're going to look, I think, to start with an H13, the amendment that you all had discussed yesterday with the Agency of Human Services, and that is on today's calendar with all of your names on it, but we haven't actually looked at the language. So we will look at that.
Is it posted? No. Well, I can't find it.
It's probably not posted. It is on the
Okay.
calendar. I can take it down and send it to Kiki so she can post it while I am talking about it.
Thank you.
Yep. I did not do it as a strike all amendment, although I did strike section 2 and put in a new section 2.
Thank
So, and I'm just gonna look also at the it won't be found from AHS to help me remember what we changed. So in this amendment, first we're striking out section 2 in its entirety, putting in a new section 2, but the actual changes in here are changing throughout. Determine payment rates to calculate payment rates. So calculate, you'll see calculate in here several times. The only time I did not change it and they did not propose it is when it talks about a predictable timeline for redetermination of base rates. I think that is still accurate as determined. But also we have for informational purposes. I will say in writing this up, I'm not sure what the informational purposes necessarily means in that context. It says when calculating these payment rates, the secretary for informational purposes shall ensure the calculations take into account certain factors, but the committee had wanted it, so I put it.
What I had written down was just that AHS wanted to really underscore that they don't determine the appropriations. So
Right, I think you get there from calculations.
Yeah,
But we've got the informational purposes in here.
okay.
It's to inform them that they don't have any obligation to act on it.
Right. In which case, I think it would be clearer to put informational purposes in the lead-in language and not specifically in the part that takes into account the costs of governmental mandates and inflation.
But would require another.
But that would require another note. That was not what the administration
With
had
that,
proposed.
it's to inform, but they don't have any legal authority to,
They don't have any obligation
no obligation.
to enact what.
Right, they're gonna calculate what would be appropriate rates.
Yeah,
But it is up to the General Assembly how much money is appropriate,
Yeah.
actually
It's also up
appropriated.
to the governor how much he recommends. They support the governor's budget.
Mhm.
All right, and then we have the methodology is calculating, not determining or assessing rates. I left in because you had not seemed to approve I left in the at least studying the rates for each provider type at least once every 5 years. They had suggested at reasonable intervals in accordance with agency capacity, but it didn't seem like that was the direction the committee wanted to go. And I will say that timing was quite important to the regularity of it was quite important to the committee upstairs. That there be some actual
Oh, yeah.
rate
So
studies
less that.
happening.
Jen, the, up on top line one, the calculating error. Yes, was that a change?
Yes, everywhere it says calculating is new. It never said calculating, it said determining everywhere.
Okay. Do I need to point out each instance of
I
Lord?
don't think so. I think you can say we changed the term determine to calculate throughout.
I didn't read the 11 pages.
The
pages of the-
You too. I almost asked.
Jenny was threatening to.
Okay.
But the
I
other
would have
change
happily done.
I wanted you to see is in subsection C, which is process for provider whose financial condition places it at imminent risk of closure, and it had said may seek extraordinary financial relief, and they suggested may request provider stabilization. That's part of your conversation with them yesterday, so that changes in here. And then
As I recall, it's because that language is only used for,
it is currently in effect for nursing homes
Nursing
and
homes,
private non-medical
yeah.
institutions.
Yeah.
There's no reason you couldn't require a parallel or similar construct for other provider types. I think it's more of a policy decision than it is somehow inappropriate.
got it.
We haven't done that.
You haven't done that. This would have required the secretary to establish a process for a provider to seek extraordinary financial relief. Perhaps similar to what exists for nursing homes and PNMIs. They have asked you to take a different approach. You have put a different approach in here, but I wouldn't say you couldn't
Got it.
have used an extraordinary financial relief approach. All right, again, changed determined to recalculate and report those rates. They had suggested report that the secretary would review rates in accordance with this section at least annually and report the results of those reviews. I think with the switch to calculate, it makes sense for them to recalculate at least annually and report those rates. It still isn't requiring them to do anything more than just information. But I think review is does not have them take as active of a role as you had contemplated. I did not make any changes. Well, in section 3, the designated and specialized service agencies section, I did not make any changes except to change determine to calculate, just so that it's consistent and then still points over to the section 2 language. And then in section 4, again, I changed the determining to calculating in the description of the methodology that the agency will be developing and therefore reporting.
Okie dokie.
Hopefully that looks generally like what you expected.
Yes. Thank you so much, Jen. I appreciate it. And I appreciate you scrambling in the late hours of yesterday to do this. You. So is everyone in favor? As of right now, we're all on this amendment. Is everyone okay with that?
Yeah.
Yeah, Larry. All right, great. So we'll leave it as is.
And then I think the chair may have been interested in just kind of taking another look at 266 because it's been a while. To tee up some conversation and markup.
I think that would be great. So yeah, why don't we proceed to looking at that bill?
And I'm gonna have to leave shortly to get to my next meeting.
Okay, I'll see you after lunch. No,
Yeah, we'll see you.
See you on the floor.
I have an amendment too, not to this bill.
Okay.
So at this point, we are still looking at the as passed by House version of H 266. Right, so this is the 340B prescription drug pricing program. Adding a section 1 adds a new subchapter in Title 18 and Chapter 91, which is on prescription drug cost containment. This is regarding the 340B drug pricing program. I don't know if we need to go through the definitions again. But the main part of what's in here now is in what would be TVSA 4682 that would prohibit a manufacturer or its agent from denying, restricting, prohibiting, or otherwise interfering directly or indirectly with the acquisition of a 340B drug by or delivery to a 340B contract pharmacy on behalf of a 340B covered entity, unless the contract pharmacy is prohibited from receiving it by the U.S. Department of Health and Human Services. Would also prohibit a manufacturer or its agent from directly or indirectly requiring a 340B covered entity to submit any claims, utilization, encounter, purchase, or other data as a condition for allowing the acquisition of a 340B drug by or delivery of it to a 340B contract pharmacy. Again, unless the claims or utilization data sharing is required by the U.S. Department of Health and Human Services. It also prohibits a manufacturer or its agent from interfering with the ability of a pharmacy contracted with a 340B covered entity, so contract pharmacy, to dispense 340B drugs to eligible patients of the 340B covered entity. And it requires a manufacturer or its agent to offer or otherwise make available 340B drug pricing to a 340B covered entity or contract pharmacy in the form of a discount at the time of purchase and not through a rebate. Medicaid is unaffected. Violations, a 340B covered entity, 340B contract pharmacy, or other person injured by a manufacturer's or agent's violation of this subchapter could bring an action in Superior Court for injunctive relief, compensatory and punitive damages, costs and reasonable attorney's fees, and other appropriate relief. A violation occurs each time a prohibited act is committed. And each prohibited act is each package of 340B drugs subject to a discriminatory action by a manufacturer or an agent. Nothing should be construed to conflict with or be less restrictive than federal law. And then section 2, it's a separate section on reporting that requires hospitals that participate in the 340B drug pricing program to submit annually to the Green Mountain Care Board a report detailing the hospital's participation in the 340B program during the previous hospital fiscal year. That would be posted on the Green Mountain Care Board's website and contain at least certain information about annual estimated savings to the hospital from participating in 340B, comparing the acquisition price of drugs under the 340B program to group purchasing organization pricing. And if purchasing organization pricing is not available for a specific drug, then comparing the 340B price with the price from another generally accepted pricing source. Provide the aggregated payment amount that the hospital made to pharmacies that they contracted with to dispense drugs to the hospital's patients under the 340B program during the previous hospital fiscal year. The aggregated amount the hospital made to any other outside vendor for managing, administering, or facilitating any part of its 340B drug program. The number of claims for all prescription drugs the hospital obtained through 340B. A description of the ways that the hospital uses savings from participating in 340B to benefit its community through programs and services funded in whole or in part by 340B program savings, including services that support community access to care the hospital could not continue without the savings, and a description of the hospital's internal review and oversight of its participation in the 340B program in compliance with federal requirements. Section 3 would sunset the report after 5 years, and the act would take effect on passage with the first hospital report due on or before January 1st, 2026.
31st.
31st, what did I say? First?
Yeah.
Thank you. January 31st.
So that's it. We just went through the whole bill.
Just went through the bill.
Yeah,
With
so
the
we looked at the H13 amendment and now, yes, and now, and then I said it would be good to just refresh everyone on what's in
Are
the
we
bill.
planning to do a markup on this bill?
Well, this is it, really.
Yeah.
What about the white bagging issue that we heard about?
So I'm not sure if other people heard about it. I think you heard about it.
I heard the term. I don't know much more
Who
than that.
brought that to us? Do we know? To repeal white bagging? don't recall for savings. Well, what we'll do is why don't we land here with the bill? I don't have any, unless somebody has some proposals for change, I think at this time. And if there are, I know that the healthcare advocate had made some requests, but we haven't, I don't know if they've been submitted.
Madam Chair, we did resubmit a letter yesterday. On behalf of, I submitted the letter to the committee on behalf of Mike Fisher and Catherine O'Neill from the Green Mountain Care Board. I believe it's posted to your website.
Kiki, do we have that letter posted then?
Yeah. Do you want to have
Yeah.
Charlie walk by that
Let me
while
just
she's
take a
here?
few minutes for you to go through that with us. That would be helpful.
Sure.
I do have it. And the hospitals are here, so we can get an instant response. And accuracies, right? Got it. Well, I think it was Jeff Hockford who mentioned the repeal of White Bank, but I can't. That's not something I. Go ahead.
So thank you. Charles Becker, staff attorney with the Office of Healthcare Advocate. For the record, our suggestions were pretty simple, simply to at 9406 to add some language suggesting that the reporting be in a form and manner prescribed by the Green Mountain Care Board. In paragraph 1, a recommendation that we replace the current paragraph, which requires reporting on a comparison of drug costs to group purchasing organization prices. That we replace that language with something that requests the actual aggregated acquisition costs for prescription drugs acquired by the hospitals, and then the aggregated payment amounts received by the hospitals for those drugs. With this type of reporting, we would get an actual accurate dollar figure of the amount of 340B revenue that hospitals are generating through the 340B program. And also here we have some language that says that we want to make clear that this is drugs that are dispensed and also administered. So this would incorporate, for example, infusions that are administered in an outpatient hospital setting. We want to capture those administered drugs. And because we understand that payments for those drugs are often under a bundled payment, that we put in here language that says that hospitals should estimate the amount of revenue they derive from these drugs, and to report to the Green Mountain Care Board the methodology they use for calculating that estimate.
If it's a bundled payment, how can the hospitals pull that out separately? I mean, I'm just asking.
I know that's a great question, and I'm sure hospital finance experts would be able to answer it
Yeah.
more accurately. My understanding is that there is, some understanding of what the drugs that is being administered costs, and then the other services that go along with administering those drugs, they have a sense of what those services cost as well, and that knowing those things, you could arrive at an estimated cost for the 340B drug. The other recommendations were to add at paragraph 3 a list of the, so we're asking for payments to vendors, but also tell us who the vendors are, and then a brief description of the work performed by those vendors. Paragraph 5, a recommendation that not only should hospitals be telling us services that are reliant on 340B revenue, but also if they're saying that they couldn't provide these services any longer, to provide some sort of analysis for why that is. A new paragraph 7, such additional information as the board may request. If we're doing this for just 5 years, we want to make the most of this opportunity. And if the board determines that they should be requesting additional information, we want to give them that authority in this 5-year window to do that. And then the final recommendation is just to replace the word savings with the word revenue throughout this section 2 of the bill, with the understanding that these aren't really savings so much as it is revenue. Hospitals get a license to essentially to purchase drugs at a low price and then to sell them at a higher price. This is revenue. It's not savings. And so that's just our recommendation there.
So I guess the thought is that if there's getting it at a lower price, they may be raising the price a bit, but are the patients also getting a savings? So
Well, I mean, I
don't know.
no, that's a great question. And I think that's something we're hoping to figure out with this data. Yeah.
Can I ask a quick question?
Sure.
On your, thank you so much for that.
You're welcome.
On your suggestion D, where it says hospitals and it talks about, making sure that they provide a detailed and quantitative data to support why they need the 340B. Is an FQHC considered a hospital?
An FQHC is not considered a hospital.
Okay.
No. So
Right.
this reporting is limited strictly to hospitals. Other covered entities, including FQHCs, are not factored into this reporting requirement.
Great, thank you.
You're welcome.
Okay, other questions? Good.
Thank you so much for the honor.
Thank you, that's
Yeah.
helpful. All right, all right, so we'll put this back up on our agenda, 266 up again, and maybe we can have a conversation about this. And we'll certainly have to have a hospitals and everyone here. And then we'll see where we go with it. So